guys. So today I have the pleasure of introducing again my friend and colleague, Dr. Matthew Currier. I've known Dr. Currier for 15 years now, a relationship that we have had going back to when we were both studying under the tutelage of Dr. Raul Guzman at Vanderbilt. And during Dr. Currier's time in the lab and my time in the lab, we managed to develop a mutual hatred of rats and mice and a love of very loud music which disturbed every other lab in the vicinity. And after extricating himself from my rather bad influence, Dr. Currier completed his general surgery residency at Vanderbilt and then went on to do his fellowship in vascular surgery at Wake Forest. And his subsequent career has involved academic positions at Emory, before returning to Wake, and he's now professor of vascular surgery at the University of Michigan, Ann Arbor. Dr. Currier is the author of numerous publications and book chapters, and he's the recipient of multiple research grants. And his academic focus has transitioned over the years from a more traditional basic science bent to a more patient-focused translational approach. And he continues to work at the vanguard of this paradigm shift in academic research, whilst at the same time maintaining an extremely robust clinical practice. Dr. Currier's dedication to improving our patient care in the field of vascular surgery has been to me both a source of both personal and professional inspiration. So I'm pleased to invite him here today to share his thoughts on the subject of peripheral arterial disease. Ladies and gentlemen, Dr. Matthew Currier.
Good morning. It's nice to be here and see the symposium growing and flourishing so much. It's a bigger room and it's still full, so that's a sign of health. Let me see if I can get my slides going here. So I'm going to be talking about evidence-based management of symptomatic PAD, and I'm primarily, for my talk, I'm going to focus about revascularization in particular. When should it be used? When should it not be used? And how do we go about thinking about how to do it once the decision's been made to pursue revascularization? These are my disclosures. PAD research and things around decision making for PAD is sort of my passion and what I love most in my academic career. And so if you want to hear more about that, we had some good discussions last night about maybe bringing some of my values clarification research trial here to Bowling Green in the future, and that would be a really exciting thing. Our learning objectives are to review the role of revascularization as a treatment option for symptomatic PAD. When should we do it? When should we avoid or not do it? And I'm going to go over some recent updates to treatment guidelines, primarily focusing on the AHA guidelines. And I'll run through some case-based examples that sort of illustrate the considerations, not necessarily pointing to an absolute right answer in any set of circumstances, but how we go about thinking about it. I was really honored to get to work and be a writing author on the recent update to the AHA guidelines for PAD management. This was a huge amount of work. It involved about 3 years of work, and it was the first major update since 2005, so it was time. And I found that process remarkable as a vascular surgeon involved in a multi-specialty group of people trying to talk about how we ought to take care of patients with PAD. And I think PAD is always a topic that touches all of us. It touches our primary care physicians. It touches specialists like me who do revascularization. It touches emergency room physicians. And I hope you can take something away from this, regardless of what your specialty is. Let's see here. Just trying to figure out how to do the pointer. This is just a summary. I'm going to be going over classes of recommendations and levels of evidence, and I think anytime you're reviewing guidelines, it's worthwhile to take note of what is the evidence to support it, The preceding talk on the Watchman I thought was great. I really enjoyed it. This is not going to be a gadget talk. It's not going to be a talk about cool techniques, and I think in PAD care in particular, the technology is exploding way, way, way ahead of the evidence to support one particular management strategy or another. This talk is going to be more about the blocking and tackling of PAD management and how to treat patients and what to do. So launching right in, revascularization for claudication is a class 2A recommendation, and I think it's important to remember in our patients with claudication, the majority of them will not progress to critical limb ischemia. In most big series, it's less than 10% of patients. And I think as a provider that does revascularization, we have to be good stewards of the resources and the decision making. And I actually had an interesting moment after moving up to the University of Michigan last year. I was actually doing a talk at the state Podiatric Medical Association, and podiatrists are actually really important partners in caring for these patients because they diagnose a lot of PAD. And the person speaking ahead of me was really championing preemptive intervention to prevent progression of asymptomatic PAD or claudication of critical limb ischemia. And I kind of rose to challenge that. That is a flawed mentality. And the average claudicant who is not smoking and is non-diabetic does not tend to do anything but stay a stable claudicant or get better with guideline-directed medical therapy, and that's a really important thing to remember. The role of revascularization for claudication is therefore not to save the leg, but to improve functional status, improve quality of life, and the approach should be individualized and have a reasonable chance of a durable response. I think in patients who are referred as newly diagnosed symptomatic PAD patients, I think it's really important to establish with them that this is a disease that we chronically manage and don't ever cure. And I think a lot of patients with PAD, in retrospect, have told me in some of the focus group research I do that they didn't realize that till several years into treatment. And I think a real key thing is to maintain a long view of what's anticipated down the road if we do the intervention and when the intervention fails in the future. Endovascular procedures have really become the mainstay of treatment for claudication. So within the AHA recommendations, it's a class 1A recommendation for patients with aortoiliac occlusive disease. It's largely replaced open surgery for all but the most severe aortoiliac occlusive disease and has really helped a lot of people. Endovascular procedures are also reasonable as a revascularization option for patients with lifestyle-limiting claudication and hemodynamically significant fempop disease. That's a 2A level evidence B from randomized trial data recommendation. However, it's a level evidence C for isolated infrapopliteal disease, and so I'm talking about the below-knee popliteal artery or tibial vessels. Patients with disease isolated to just the popliteal or tibial distribution do not tend to manifest with claudication symptoms, and the usefulness and the evidence to support good long-term outcomes with endovascular procedures is less well shown. And you can see here class 3 harm recommendations. Endovascular procedures should not be performed in patients with PAD solely to prevent progression of critical limb ischemia. How should we do endovascular techniques? Show of hands in the room if you do endovascular procedures for PAD. So there's a few of us in here, and I guess there was a lot of discussion when we did the HA guidelines about whether we ought to recommend specific strategies or combinations of strategy, and the evidence behind this gets really sticky because these procedures are often done in combination with one another. They're often done at multiple anatomic levels. In many of the trials evaluating a specific technique, whether it's drug-coated balloon, atherectomy, stent, what have you, they frequently define the enrollment based on the lesion location, and they mix patients with claudication and critical limb ischemia, and it's very, very hard to reconcile across all these studies for a specific patient's circumstances which way you ought to do it. So our recommendation was actually that how you do it ought to be based on how the lesion looks and the operator experience. You ought to, if you do procedures for claudication, you ought to do them the way that your training and experience maximizes the odds of success. And it does emphasize that lesions should be hemodynamically significant. And you can assess that a number of ways. We use CTA and MRA increasingly prior to taking patients for angiography, particularly for claudication, and I think there is a real role for that. Adjunctive measures you can use or things like endovascular ultrasound and pressure gradient assessment if you're in there, not only to determine whether the lesion's hemodynamically significant, but also to assess the result of your intervention. For aortoiliac disease, there's really good evidence that shows that endovascular treatment improves walking and health-related quality of life. And I think a thing we need to emphasize and really hit on with our patients is that you actually get a synergistic effect for endovascular treatment plus supervised exercise therapy than either of those treatments alone. And I think a flawed mentality we sometimes have is we try a patient with PAD on supervised exercise therapy, we put them on a walking regimen, and they get a suboptimal symptomatic response, and then we move on to revascularization, but the patient who has had a successful angioplasty or endovascular intervention still gets gains out of the walking exercise, and we need to revisit and bring that part of the therapy along instead of moving past it. And that's something I try to really emphasize with our residents and fellows when we're seeing these patients in clinic. Fempop disease also has multiple randomized trials demonstrating efficacy of endovascular treatment. However, compared to aortoiliac disease, when we line endovascular treatment for Fempop disease up against supervised exercise therapy, the curves start to look about the same in a year. So there's a wane in the treatment response in terms of quality of life. It's partially related to durability and what affects our durability of our endovascular treatment of Fempop disease. Well, patency obviously is a surrogate of durability, but long lesions, total occlusions instead of stenosis, runoff, and when I say runoff, I talk about the tibial and distal vessels that are patent as outflow distal to the intervention. And down here, diabetes, CKD, and smoking. These are all adverse predictors of a durable benefit from revascularization. I personally do not offer patients who are actively smoking Fempop revascularization if they're just claudicants, because we are setting that patient up to have a failed intervention and potentially escalate or progress in terms of symptoms when it fails. And so a really important aspect, and I saw we're having a session on smoking cessation here, which I think is great, is partnering with these patients and making them understand that the smoking is very much part of the strategy, and I think it's sometimes challenging to engage a patient who feels like they're being denied a revascularization they think they need. But by the same token, I think forging ahead is often setting them up to be in a really complicated situation down the road, and that is just such an important aspect of their care. As we see at the bottom here, patency for Fempop interventions is lower than iliac interventions, and that's why there's a difference in the level of evidence. So the summary paragraph is that the choice of endovascular therapy for claudication for Fempop disease should include discussion of the outcomes, addressing the risk of restenosis and repeat intervention. It's something you ought to bring up before they have their first procedure, and particularly for lesions that have poor likelihood of long-term durability. It's sometimes best to think twice. A good retreat sometimes beats a bad stand. For isolated infrapopliteal disease, as we said before, here's the downsides of endovascular intervention for below-knee popliteal or tibial lesions. It's unlikely to be a cause of claudication as symptoms. Restenosis incidence is very high. Limited long-term benefit has been demonstrated. So, of course, these procedures can get done, but the long-term benefit is not well established. There are some emerging data for drug-coated balloons that suggest patency benefits out past a year. That information was published. We decided not to include it in the trial or in the updated guidelines because it's not really mature and hasn't been validated across enough studies. However, in these studies, again, it's not claudication-specific enrollment. It's all-comer groups of patients, which makes the interpretation of results challenging. And even though they have a moderate patency benefit for the drug-coated balloons, there were no clinically meaningful differences beyond patency. So their walking function, quality of life were similar in both groups. And for those of you who run your own imaging suite or office procedure, area. These are more expensive devices. They require the patient to be on a more prolonged antiplatelet therapy, and there's other considerations. And again, class 3 harm, we shouldn't be doing procedures to prevent progression to critical limb ischemia. Surgical revascularization for claudication is still a great treatment, but it's increasingly becoming something that we use as plan B with a previous failed intervention, or when there's circumstances that would otherwise make endovascular treatment less desirable. And I would say that of the PAD procedures I do for claudication, open surgery anymore probably accounts for maybe 10% of them, and a lot of it is in situations where we're dealing with common femoral disease. So when you do surgical revascularization, however, you need an autogenous vein if you're doing a bypass below the knee. And we were talking last night about this. If I take a patient to the angio suite and I'm going to do an endovascular intervention, it's really good to go ahead and get a vein mapping even if I don't have a bypass procedure planned. I like having that information because it tells me what the anticipated outcome and how good a candidate the patient is for surgery if the endovascular treatment is not ideal or technically difficult. On the contrary, if I know there's not good piece of single segment saphenous vein, it lets you know that if you push the envelope, you don't have that same bailout in a critical limb ischemia situation, which we'll get to in a minute. You might want to push the envelope more with the endovascular treatment. It shows up here that surgical procedures like endovascular, there's a recommendation 2A level evidence B from non-randomized studies. The big difference is the perioperative risk assessment probably needs to be a little bit more robust. We're talking about surgical revascularization. These procedures are often require general anesthesia, and it's a little bit more to put the patient through. And so we think about that and get a little more aggressive with screening them, especially if the claudication is lifestyle limiting to the point where their METs are low and they don't ambulate enough to get themselves into angina. 3 harm recommendation, we should not be doing femtib bypasses with a prosthetic graft for claudication. Patency is poor, unlikely to be causing the symptoms, and the same thing applies that we said for endovascular treatment. We shouldn't be doing these procedures to prevent progression of critical limb ischemia. Why do we recommend autogenous vein? Well, the conduit and the site of the popliteal anastomosis are really important determinants of outcomes. For either above or below knee popliteal bypass, there's really good randomized data that shows that autogenous vein has better outcomes in terms of both complications and long-term patency. And the implications if you get a surgical site infection are really more serious if you have a prosthetic graft in place. When are these procedures reasonable then? When would you do surgery? The patient needs to be acceptable risk. There need to be technical factors that suggest there's an advantage over endovascular procedures. I don't know of a place in this day and age that has the resources to do them where endovascular first hasn't become the mainstay of claudication treatment. And I'll go over what those might be. We know surgical procedures are effective, but there's really sparse evidence to support surgery over endovascular treatment over exercise for claudication, including some recent Cochrane database reviews and AHRQ reviews. Again, we shouldn't be doing the prevent. So let's do a case example. This is a 59-year-old woman, so pretty young for the vascular surgery clinic anyway, who came in with left buttock pain that bothered her during exercise. She could walk 1 or 2 blocks. Really functional person. This was getting in her way of recreation and attempts actually to exercise to lose weight. She had been advised to lose weight by her primary care physician. Did not have symptoms in her contralateral leg. And you can see over here, this is a set of ABIs done in our diagnostic vascular unit. And I don't know how well it projects, but she basically has normal resting ABIs on the right, triphasic waveforms here, good digital waveforms, and borderline ABIs, but above 0.9 on the left with waveforms that really look quite similar in the symptomatic leg. So this patient, this is a new part of the guidelines that took a long time to hammer out, but this is the new algorithm for diagnosing suspected PAD, not critical limb ischemia. And this lady falls in the red circle here, so she has a borderline ankle brachial index that's between 0.9 and 0.99 on the symptomatic leg, and she has exertional non-joint related leg symptoms, and that's what I mean by claudication. So we think she has the right symptoms, and this tells us in this situation the next test we ought to get is an exercise ABI. And here's our exercise ABI result. You can see the blue line here is her brachial pressures, and on the right, she had a decrease in her ABI, but rebounded to within 10% of the brachial pressures at 2 minutes. However, she had a sustained, durable drop in her ABIs out to 5 minutes of ambulation on a treadmill. It did not return to within 10% of her brachial pressure. So this is a positive exercise ABI test. She had previously failed exercise, as I mentioned before, and I actually put this patient on cilostazol or Plital, and that's the only FDA-approved medication for symptomatic management of claudication. I'm not really going to focus on that. And so we got a CTA on this patient, and this is an interesting disease distribution in a woman, former smoker, but you can see her head's up here, feet are down here. Here's her aortic bifurcation. And you can see she's got a really densely calcified distal abdominal aorta. And in cross-section on the symptomatic side, you can see that she's got pretty near obliteration of her left common iliac artery. So this is a hemodynamically significant lesion. We took this patient with this finding to the angio suite. You can see here we got a pigtail catheter up, and you can see her left common iliac artery lesion. And, lesion right here, did a balloon angioplasty. Was some concern about whether we would crack or rupture that lesion. This is actually a balloon-mounted covered stent we put in place, but didn't have any issues with contrast extravasation. You see we actually managed to maintain patency of this lumbar. She had a great symptomatic response. Was very appreciative. So that's sort of an appropriate workup for a claudicant. We're going to move on to critical limb ischemia now. How do we define critical limb ischemia? This is a topic that's important because it's distinct from acute limb ischemia. Critical limb ischemia is chronic, so it's been going on for more than 2 weeks of ischemic rest pain, meaning constant pain in the foot, toes, or legs, or non-healing wounds or ulcers or gangrene in one or both legs attributable to objectively proven arterial occlusive disease. So diagnosing CLI requires both symptoms and signs. You can confirm the arterial disease with ABIs, TBIs, transcutaneous oxygen, or skin perfusion pressures. And sometimes these additional information can be useful. However, a really, really low ABI or TBI without the symptoms is not critical limb ischemia. So you can actually have ABIs in the 0.55, 0.6 range, but the patient isn't symptomatic. That is not a call to go do something to them with a procedure. And the chronicity of it distinguishes it from a critical limb ischemia. This is a new part of the guideline too. It's recommending a team of interdisciplinary professionals to take care of patients with critical limb ischemia. And who are the components of that team? Well, it really depends on who's available in the local environment where you are. You need people that can do revascularization procedures with endovascular or surgical techniques. You need people who are willing and able to engage for wound healing therapies, assess wounds and manage them on a chronic basis, foot surgery for digital gangrene when toe amputations are required, and medical evaluation and care for risk reduction therapy. So here's a whole host of folks that can potentially be involved but aren't all necessarily involved at every center. I can tell you at University of Michigan, we do have a multidisciplinary team dedicated to we have a dedicated PAD clinic, and in our shop we have a dedicated nurse practitioner. We have some very excellent vascular medicine physicians that staff it, and then the people who do procedures at staff it include vascular surgeons, interventional radiologists, and cardiologists. We also collaborate pretty extensively with our podiatrists and plastic surgeons and endocrinologists, although we haven't been able to lure them into our multidisciplinary clinic space as of this point. I think that would actually make their care better. Here's our diagnostic testing algorithm for suspected critical limb ischemia. I'm going to wrap up. How much more time do I have? 5 minutes, okay. And I'll let you just refer to this for the sake of time. Different between claudication and critical limb ischemia is if a patient can have a revascularization, they need to have one. So this is non-randomized level 1, and there's never going to be a randomized study till we have a decent alternative therapy to revascularization for CLI. And it talks about the interdisciplinary care team before amputation. And what that means is if a patient is in an environment, we're very interested in getting out of the mentality of dealing with CLI with an amputation if limb salvage is possible. And it's a really good idea to get a second opinion before committing to that, because an amputation, just like a revascularization, can't be taken back once it's done. Endovascular procedures, again, class 1 level of evidence B with randomized data is good treatment when it's possible. Staged approaches have been added as a 2A, meaning if you have a patient with iliac and fempop disease or tibial disease with CLI, it's reasonable if you need 2 different kind of accesses to treat them with 2 different procedures if you feel like that's the lowest risk. The lesion characteristics should help you pick how to treat it. A lot of talk about angiosome-directed therapy, and we basically found, it's a 2B level of evidence B. There is emerging data published actually in the last month suggesting that there may be benefits to angiosome-directed therapy or treating multiple tibial vessels in the setting of CLI. I'm not going to touch on that today, but can answer questions about it. This is a new table within the recommendations that basically discuss what anatomic situations should make you think of surgical versus endovascular. And I want to add that these are considered from the perspective if the patient's a good candidate for both, they should get an endovascular treatment because it's lower risk. Things that would favor consideration of surgery, what are they then? Lesion involving the common femoral artery or the origin of the deep femoral artery. That's an area that's prone to stent fracture, and deep femoral artery thrombosis is a very, very difficult problem to deal with if it happens because that patient oftentimes won't heal an amputation. Long segment lesions, diffuse multi-level disease that would require endovascular treatment at multiple anatomic levels. That's a really soft indication for surgery, in my opinion. Teeny tiny arteries, particularly in female patients, may have inferior outcomes when you're trying to treat distal disease because stent patency and stent diameter compatibility is minimal. And single distal runoff to the ankle, we take that serious in terms of if we're doing endovascular treatment, we want to be sure we don't burn a bridge or make it worse if we can't salvage later. So here's a patient that presented with digital gangrene, neuropathy, had a great toe gangrene. We took him directly to angiography, and you can see here he's got multi-level disease. He occludes his superficial femoral artery at the level of the thigh. This is the level of his femoral condyle, so he's got this really focal lesion of his below-knee popliteal artery, and he's got disease but intact single vessel AT runoff to the foot. This is a patient I took and treated with endovascular treatment. Yeah, he has single vessel runoff. I treated this with a drug-coated balloon. We got his toe amputation to heal, and I consider that a short-term win. Will he be back down the road? Probably. We still have great options for surgery or repeat endovascular intervention when necessary. Same as with claudication, if we do a bypass, autogenous vein needs to be used. However, for CLI, a prosthetic bypass below the knee is an acceptable option if there's minimal decent alternative options. They talk about inline blood flow to the foot, so we, whenever possible, choose a target where there's no intervening disease between the bypass target and the wound, and staged approaches are reasonable for surgical procedures just like endovascular procedures. Here's another gentleman that came in at 78 years old. When he got started, he was a claudicant. He has a stent sitting in his common femoral artery that on this angiogram from the physician that sent him to me, you can see there's no patency of his common femoral artery here. So he's got an in-stent restenosis with a covered deep femoral artery. And over here, we were discussing the vein mapping. This is positive clip sign. He's had his saphenous vein shucked out of both legs. So these are the kind of things you like to know when you're deciding how to treat a patient. I took this patient and we did a femoral endarterectomy and an extended profundoplasty and took part of that stent out. And so those indications for why surgery in him are shown here. Here's another 81-year-old man with rest pain, ongoing smoker, and in CLI we're forced to use revascularization in that situation. You can see here that he's got a really profound drop-off distal to his proximal thigh, so it looks like he's got fempop, iliac, and tibial disease. And he also, screen left here, I don't know how well this projects, but you can actually see on plain fluoroscopy with no dye, calcium casts of his deep and superficial femoral arteries, always worrisome. And then you can also see he's got a really focal common femoral lesion here. He's got a deep femoral artery occlusion. He's got in-stent restenosis. His entire SFA has been stented down to his knee, and you can see he's got a popliteal occlusion with tibial occlusive disease and horrible distal runoff. So this is a patient I take and did a peroneal or a femperineal bypass on, and he has basically every one of these satisfying his qualifications for surgery. So I'm going to wrap up now. I put these links in here. The updated AHA guidelines are actually free. You don't have to have online subscription and circulation if you'd like to print them and look them over. I think there's a really good thing to refer to, particularly the new diagrams. These are the SVS guidelines, which are claudication specific, and this is a link to a webinar I did for AHA on this topic a few months ago if you have are an AHA member and need something to lull you to sleep at night. So thanks again for having me. I hope this was useful and practical for everybody in the audience, and I'd love to take questions if you have them. Thank you.
Thanks, Matt. It was an excellent talk, and I think, is this on? Anyway, you can probably hear me. I think it's really important to revisit. It's really important to revisit these issues, because certainly with the advent of endovascular techniques, unfortunately, given their relative simplicity in terms of when you compare to an open surgical bypass, that it unfortunately has led to a lot more of this for claudication. And I completely concur with you that there is absolutely no indication to revascularize a claudicant who will not undergo lifestyle modifying factor modification.
Yeah, I agree with that. I think in some of the patients who have inflow disease, aortoiliac disease, we maybe move a little quicker to a revascularization because they have worse odds at succeeding or getting a good symptomatic response with salocitol or exercise. But if they're willing to try it, and I have had that odd patient that doesn't need a revascularization, and it's an easy thing and it's a lucrative thing for some people to jump right in and just take everybody to the cath lab. But I think we need to be good stewards of this, and I completely agree.
And I think another thing that's poorly understood when it comes to endovascular therapy for say isolated claudication as a result of SFA disease is that the disruption of the collaterals that occurs during that procedure, which is not something that necessarily happens with a open surgical revascularization with a vein conduit. Would you agree?
Yeah, that's an interest of mine, and a question we always have. There are some claudicants that when their intervention fails, they just go back to being a claudicant, and there are others that progress to critical limb ischemia. And I do think this collateral thrombosis probably plays a role in that. We did a quality of life study recently in a cohort of about 30 patients with critical limb ischemia, and I was actually stunned because about a quarter of them started out as claudicants. And so I think that's something that we need to explore a little more. Yeah, but I also think when you're taking a claudicant, I think some of those patients really benefit from revascularization. You need to talk about all this with them so that if they do have a late failure of their intervention or they do go home and think about picking up a cigarette again, that's on their mind and it's not a surprise to them if you end up in that situation.
Go ahead, Dr. Singh.
I got two questions for you, Dr. Courier. So when I'm seeing a patient who's got peripheral vascular disease in my clinic, whether it's endovascular or they're new to me, I ask them, how much do you smoke or how much did you smoke? I never ask them, do you smoke? I've not seen that correlation with coronary artery disease. Would you shed some light on why the correlation between smoking and peripheral vascular disease is much stronger than smoking and coronary artery disease? Are you aware of?
I agree completely. I can't say I understand it completely. I'll also say that we're getting better and better evidence. There's really good evidence that smoking really, really damages our outcomes from revascularization. So it's not just an epidemiologic predictor of getting the disease, but it's also a treatment failure predictor. Oddly enough, the evidence for that for endovascular interventions in smoking is less robust, which I find fascinating, and I don't know if that's a real lack of evidence or just lack of the right study to show it. But I think it ought to affect our mentality, and it's interesting. I interact with my cardiologists at University of Michigan a ton because we're always thinking about and worried about silent coronary disease in these folks, and I think it can be a really complicated decision about who ought we to screen versus not with things like a stress test. A lot of times we end up sort of creating a confusing situation where someone's got a small reversible lesion, but they've also got critical limb ischemia, and you have a kind of a time-sensitive nature to it. So I don't have an answer back to your question to why smoking seems to manifest more commonly as PAD than coronary disease, but I think that's a really interesting
It's
observation.
very interesting. Second question I have is, how much faith do you have in resting ABIs? Now, some of the things which would confound, as you mentioned, is this calcification, but more than that, my worry is an occluded SFA with a lot of collaterals. If you do a resting ABI, chances are, it might not be normal, but there's a good chance it might be normal unless you exercise them to bring that out. Would you just give us your suggestions as to how you approach?
So I think if they have the right story, and it sounds like claudication, and it's a typical story, so muscular pain in the legs that goes away when they rest a while at a consistent distance, I think you're obliged to keep looking. And so in those situations, I like to get a TBI, particularly if it's a diabetic patient. I don't find things like oximetry as useful for claudicants as I use it a little more frequently in my critical limb ischemia patients. I think an exercise ABI is great. It's something that you have to have the time and the staff to do. It can be a hard thing to work in during a visit. And so, but that would be the mainstay of the treatment for me. And if your exercise ABI is negative, and you have a really dissatisfied patient or it's bothering you, I think it's fine to get an MRA on that patient. I tend to use MRA when I'm interested in ruling out PAD. It's also great for diagnosing, but at least in our shop, has a tendency to slightly overestimate hemodynamic significance. So if I really think I'm going to do an intervention and I'm trying to plan it, I tend to lean towards CTA. But in a situation like you're describing, where we're trying to make sure we're not missing PAD due to a false negative test, an MR is a great option.
So that goes against fairly conventional wisdom, doesn't it? Getting an MRA in that circumstance, you're not using that as a roadmap for an intervention. You're using it purely as a diagnostic tool.
That's true. I also think, though, that's in a situation where there's diagnostic uncertainty. I think the bigger, lower value use of MRA is the patient who's got minor symptoms that are not lifestyle limiting. They have a positive ABI, and we're trying to decide they get sent to see somebody like me to decide, do they need an intervention, and they come with an MRA under their arm. It's not part of the standard workup, and I would stop short of cross-sectional imaging in a patient like that, where we're going to give either cilostazol, exercise, both, or even just observation a try. So an MRA is not a great treatment for the patient that is sort of screened for PAD and it's identified, has really minimal symptoms, and is glad to know that they don't need a procedure. Stop short, you don't need to get an MRA in that person.
So it's interesting that you mention all these tests, and in this day and age, we're trying to be more cost effective and cost efficient. So if you have a patient that has pretty straightforward claudication and they failed exercise therapy, and you know you're going to end up with an angiogram, how often do you go straight and do an angiogram versus do an MRA, CTA, do a TBI, do exercise ABIs? You know what I'm saying?
I'll tell you what, I really commonly will get a CTA before taking an elective claudicant to the cath lab. I think finding new information that's surprising to you that you wish you'd known, I like to go in with a really well sorted out plan for what I'm going to do. I get lesion characteristics off that study. If I think I might need an atherectomy, or I think I might need a covered stent because I'm worried about cracking a lesion, and a great example is an administrator that works in our cardiovascular center came to see me with really typical inflow symptoms, and I was thinking she was, just a plain Jane iliac angioplasty is what she needed, and I CTA'd her. She had a really focal, densely calcified lesion in her infrarenal aorta, and I ended up treating her with a covered stent with a cuff for a stent graft, which I guess I have to say that's off-label use, but it's nice to be prepared for that situation, and you've got the equipment you need, and there's not a lot of confusion. And so I do think in patients with critical limb ischemia, I do move a lot quicker to get an angio because the odds that I'm going to leave it alone are nil if they're a candidate for a revascularization. But your point's well taken. We spend more money doing it that way.
I just want to hover on the same concept, what Dr. Singh was saying. I get a lot of referrals from you guys for cardiac clearances with peripheral vascular disease, and how often I see abdominal cardiac perfusion imaging. I mean, to me, once in a while.
Yeah.
So in fact, even if we do cardiac catheterization on them, we may not find significant CAD.
No,
So that's a very big disparity.
it's something we need to figure out how to do more efficiently. And that patient, I showed the angio with the in-stent stenosis in his common femoral artery. That patient, I took him to do his leg bypass operation, and they induced anesthesia. I didn't get a stress test. He does almost nothing. They induced anesthesia, and he had a big MI. We didn't even cut him at all. We just put him to sleep, and while we were prepping him, he had EKG changes, had a pretty big MI. Stopped the case, aborted, got him through all that, had him seen by his cardiologist as an outpatient, and ended up getting a cath, and they recommended medical management, and I ended up back in the OR with him with, the same circumstances. And so we do spin our wheels a lot. And I think the thing that bothers me is these patients that do very minimal, the severe claudicant or the patient with critical limb ischemia that basically does not walk beyond, from their couch to their front door. Those patients are a mystery. And a lot of times the urging to get these tests is coming from my anesthesia colleagues who have to deal with the consequences if we miss something bad in the OR. But I don't have, there's a separate, very, very long AHA guideline for perioperative cardiac testing that I refer to a lot, but I think there's an art to this that I haven't completely figured out in terms of, I do think there is overuse of screening in some of these situations, but on the flip side, I've never been sorry if I have a big periop cardiac event. It makes me feel worse if we didn't look into that ahead of time, and it's something in our morbidity and mortality conferences we talk about. This patient had a cardiac event, didn't get a pre-op stress test. That doesn't mean that the pre-op stress test or anything that came after it would have made that avoidable, but it's something we scratch our head about a lot.
The concept of plaque rupture is not explained. Cardiac perfusion can be normal. The specificity and sensitivity is about 75%.
Yeah.
So as long as the students understand that.
And I think, to be honest, there's also, it's not the best science and it's not evidence-based care, which is the title of my talk, but there's also, I think, a lot of liability concerns that gets on people's mind. If you have a patient who has a big MI after an elective procedure for claudication, it probably affects your threshold to screen the next one you see. That's just human nature, I guess.
Any more questions? I certainly would say that I do not practice evidence-based medicine when it comes to cardiac clearance. I get Dr. Kazmadine and his partners to clear my patients for any open revascularization, be it an aortic, lower extremity, or carotid, and I have never been sorry. He's saved my ass more than once.
And I'll just to echo that, in coming to University of Michigan last year, I was pretty selective, and I was sort of blown away that they are a lot more aggressive than we were at Wake Forest, where I think we have one of the densest smoking populations in the world about screening people. And so I think there's a lot of local culture at each place that goes into this too. Thank you.
Thank you.